again, and I'm not sure what compelled you to come in here other than our fine speakers, because it certainly wasn't me. We're going to get started here. We are on a tight schedule, so just for those who are going to be staying with us for the majority of the day, or at least the morning, we have 30-minute blocks. We're going to try to get you out here in 25 minutes so you can get to the next session. We'll have approximately 20 minutes of lecturing from our speakers and 5 minutes of questions there afterwards. So I do encourage you to save up your questions and pick the brains of our esteemed speakers here. So first up we have Gail Woodbury. Dr. Gail Woodbury is an epidemiologist whose clinical background is in physical therapy. Previously, Dr. Woodbury was on the faculty of wound healing at the Western University in London, Ontario, and she served on the board of CAWC. She's participated in multiple interprofessional wound care courses in Toronto. Currently, she's an adjunct faculty member at the School of Rehab Therapy at Queen's University in Kingston, where she teaches both OT and PT. Dr. Gail Woodbury.
Good morning, everybody. It's nice to see so many people here. When there were so many streams, I thought there were going to be 4 people here. So I'm really glad that there are a lot more than 4. It's great. So, I don't have any conflicts of interest. That's the first thing I wanted to tell you. So this is what we're going to do this morning. I'm going to talk to you about the economic burden of diabetes-related foot complications in Canada, and I'm going to also tell you a little bit about the U.S. I'm going to discuss the personal burden of diabetes-related foot complications on patients, and then we are going to review methods that we can think about in terms of dealing with the problems that we're seeing with diabetic foot complications. This is in a terrible position. I can see this here and I can't see that, and so it's not very easy. Anyway, there are certain things that we know, and this is sort of a review. You all know this, but I just wanted to point out a couple of things. We know that we're an aging population, and we also know that as we age, there are going to be more people with diabetes, and that we live with a lot of sugar around us and a lot of obesity and a lack of exercise, and so we're seeing more and more diabetes, and that's a serious problem. This chart shows the prevalence of diabetes going up, or the prevalence of, what have I got here? Diabetes by age and sex going along there. So you can see that it's a problem, because as we're all aging, there's more and more diabetes. The worldwide prevalence of diabetes is 415 million now, and it's projected to be in 2014 642 million. So we've really got a problem going forward. We also know that 2.4 million Canadians have diabetes. 15% of people with diabetes will develop a foot ulcer in their lifetime. 50% of lower extremity amputations are due to diabetic foot ulcers. And people with diabetes are 20 times more likely than people without diabetes to have a non-traumatic lower extremity amputation. So that's some background. So let's talk about the financial costs. There's a wonderful article. Oops, this is not there yet. Okay, so this slide shows you that on the left-hand side, these are the countries that have the greatest number of people with diabetes, and we're not there. Canada's not there. However, these are the expenditures for diabetes, and Canada is on this list. So although we don't have as much as many other countries, we're spending a lot of money on diabetes. And this one shows the same statistics. So in US dollars, Canada's spending about $17 billion now on diabetes. And it's projected to be $22 billion by 2040. Okay, so that's a lot of money. So there's a wonderful article that was written by Hopkins et al. And published in 2015, where they looked at the prevalence and the incidence of diabetic foot ulcers. And they found that 75 people per 100,000 had diabetic foot ulcers. And the number increased from 2007 to 2011, and that increase represented 7% per year over the 5-year period. So that's the prevalence of diabetic foot ulcers going up in over a 5-year period. And the incidence was found to be 42 per 100,000 population. So once again, we're getting, so the incidence is the new cases of diabetic foot ulcers. So incidence is the new cases and prevalence is the ones that exist in the population. So in this study, they looked at data from CIHI, from the Canadian Institutes of Health Information, and you don't need to read this slide except that it does show you what the databases were that they merged, and the costs that I'm going to show you in a moment are from the payer perspective. So the total cost to the healthcare system in Canada is $547 million on diabetic foot ulcers. That's the overall cost. Some of it's in acute care, some of it's in home care, and some of it's in long-term care. But the average cost of a prevalent case, so if people have the ulcers, the average cost is $21,000. So that's a lot of money. These are the costs broken down, and what I wanted to show you here is there's the total cost that was in the previous slide, but look at the number of admissions that there are for diabetic foot ulcers. Look at the amount of money that is being spent on admissions to hospital. So the costs are quite phenomenal. Then in the same study, they followed incident cases. They found the people who developed new I don't know why I've got pressure ulcers on the brain, diabetic foot ulcers. And they followed them over a 3-year period. And the total, this shows you that there were 5,000 incident cases, and they were followed, and there were 26% of those people died in the 3-year period. So that's a quarter of them died in that short time. So there are a lot of deaths as a result of diabetic foot ulcers. It's a big concern. So these are the costs for the 3-year period, and I think these are quite interesting. So the total cost is $52,000. For acute care, it's about $20,000, and for non-acute care, it's $31,000. I have that on the next slide, and it's broken down, and what I want to show you is, you don't have to read this whole slide, but what I do want to show you is for the total acute care cost, the costs for admissions are really quite high. So out of the total of $20,000, $18,000 for admissions, and then there are some for emergency room and some for procedures. So the other thing that's interesting is they were able to find out the informal caregiver costs from the MDS data. And look at the amount that is spent on informal caregiving. So this is in people who are in home care. Their direct costs are this amount, $8,000, and their informal caregiving costs are $11,000. So that's money that's actually not being spent by the healthcare system. It's being swallowed up by the informal caregivers of patients. And that was a finding that I haven't seen anywhere else, so I found that quite interesting. How am I doing for time? Now I just wanted to show you a couple of slides about the U.S. and this is a study where they compared people with diabetic foot ulcers who had diabetes and those without diabetes, and this is the database from which these data came. So they looked at the ratio of diabetes versus non-diabetes admissions. 90% of diabetes admissions were due to neuropathy and infection. And I think you're going to hear some more about infection later on this morning. Peripheral vascular disease accounted for most of the non-diabetes admissions. Admissions related to infection rose significantly among the diabetes patients. so that they went up in 2005 from 39,000 to 51,000 in 2010, while the admissions for non-diabetes people stayed stable. So what does that cost? So for diabetes, the diabetes admissions cost $1.38 billion versus $0.13 billion for non-diabetes. So diabetes costs. Diabetic foot infections, there were over $11,000 spent on per diabetic foot admissions for infection and only $8,000 for all other causes. And what we see here is a statistic we've seen for a long time, but it's being underlined. There are about 83% of major amputations and 96% of minor amputations are the result of diabetic foot ulcers. The hospital costs have been increasing in the U.S. over the years that this study was done because people are sicker. So there are more comorbidities for people with diabetes than there used to be. In the past it was 7.7, now it's 22.2, and the per patient cost related to the comorbidities has gone up from 23,000 to 30,000. And the per patient costs related to ischemia have gone up from 34,000 to 49,000. So there are lots of costs. So that's the financial cost. I also wanted to talk to you for a couple of minutes about the human cost, because as healthcare providers, we need to know about the human costs as well. So this basically shows you that for people with diabetes, they report their health to be poor, and as you can see, they are the darker bar graphs. It goes up with age, as it does for older people anyway, but look how much more they report poor health than people without diabetes. So what I've picked out is I've picked out a few variables that are related with diabetic foot ulcers. People with diabetic foot ulcers report lower quality of life, and there are several, wrong button. Sorry. There are several studies that report that, but one of the things that they report is that they have lower mobility function, and that's important for us to think about in terms of them being able to have a healthy lifestyle, get some exercise, to live a good life. And the variables that were associated with negative quality of life include things like age, unemployment, their income, those kinds of things. The ulcer duration from 1 to 3 months. So those are the new ulcers, when they're coming to the realization that, gosh, I've got to live with this now. So that's quality of life. Depression. So this study, which shows that people with a major depression were more likely to develop a diabetic foot ulcer, which I thought was a rather interesting thing to know about. So if you've got patients who are depressed, you better watch out for their first diabetic foot ulcer, perhaps. Amputation. So this is a qualitative study about the lived experience of amputation, and there were several themes that emerged. People are concerned about their finances. They feel powerless. They need social support. There's talk about placing blame, and their uncertainty about their continued ability to do the things that they would normally do in their lives. And that's an important issue. That was in another study as well, where they talked about needing to develop resiliency to live with their diabetic foot ulcers and potentially their amputations. And I thought this was interesting. This one was published in 2016, and this was about illness beliefs. So ischemia and illness beliefs were significant predictors of time to death. But these illness beliefs were a significant independent effect. They by themselves, they were important, and they were things like, what do you think about your disease? How sick is it going to make you feel? How much control do I have over my disease? Things like that. And I think this is important, especially when we're dealing with people who have diabetes and you're trying to treat them and care for them. And And you have to remember that we all come from different contexts, and so it's important to know what people's illness beliefs are in fact. So I've just kind of summarized the thinking about a human cost in terms of, we want to think about them when we do client-centered care, patient-centered care, and support them while they're coping and living with their diabetes, in the risk of diabetic foot ulceration development, their participation in treatment, whether or not their ulcer is going to heal, and in terms of amputation, and also in terms of death. So, what can be done? So this is your opportunity to tell me what you think can be done. And I know you're going to hear a lot about diabetes today and diabetic foot ulcers, but they're a big problem, they're a big financial cost, and they're a big human cost. How's my time? Am I okay? Yep. Yep. So let's have some thoughts that you have. What are you going to do about diabetic foot ulcers and people with diabetes? What are your thoughts? Anybody? Yes, a hand.
I work in the community, and then when you move here to Champion, they're trying to specialize me in actually diabetic foot ulcers. So in community, we often find that someone who's on diabetes, probably with an ulcer, but 50% of patients are diabetic ulcers. So I'm working on something that is a screening technique. So I would go in and do a 1 to 2 hour session, basically educating and following up.
So this is diabetic. This is foot complication screening?
Yes.
Yes.
And ongoing, not just leaving them with that, and then they're on for 5 years and never get re-educated.
Right. Okay. So is that for healthcare providers or for the patients?
Sorry.
Is that for the healthcare providers or for the patients that you're doing this?
For the patients, and I would also do learning sessions with the nurses.
Very good. So we're talking about prevention, we're talking about screening. Wonderful. Okay. Anybody else? Any other thoughts? Yeah.
I work in the Hamilton, Niagara, Haldeman brand, LIN, and we have a Peak First Steps for Health program, which does diabetic foot prevention and interventions and screening as well. And right now we're looking to pilot an expansion that might actually include wound care because it's a natural evolution to the risk. But currently it's not funded within our program, and we would like to have maybe a second tier that would include that and help to bring people with exposure back into our prevention care.
Great. That sounds very interesting. Great. Yeah?
I'm a wound care specialist in the Ottawa area.
Can everyone hear her?
Working in home care in Ottawa, wound care specialist. And what we're going to start doing is training with our nurses on the infrared thermometer. So
Right.
we can predict bone changes and help to get the patient to, alleviate pressure, et cetera, to predict an ulcer that's coming on.
Very good. Anybody else? One more. Anybody else?
Regular foot care. Finding regular foot care, so they're getting their feet assessed on a 6 to 8 week basis.
Okay, very good. So regular foot care by foot care nurses. Okay, very good. Thank you. So I gave this some thought as well. So this is an article that was published in 2016 as well. For every euro, obviously it's not Canadian, for every euro spent on ulcer prevention, 10 are spent on ulcer healing. And for every randomized controlled trial conducted on prevention, 10 are conducted on healing. So they're making the argument that if we spent some money on prevention, we wouldn't have to spend quite so much money, waste so much money on healing. And we all know that. I think I'm preaching to the converted here. But also we need more research on prevention. We don't have the studies that actually show it works, although intuitively you'd think it would. So I've sort of summed up my thoughts about it in terms of we need education for everybody, for the patients and for the healthcare providers. We need screening for foot complications. But I also think that we need education to prevent type 2 diabetes as well. I think we need to go a step backwards and stop eating sugar and start getting more exercise and encouraging other people to do the same kinds of things, and that we need to be screening for diabetes a lot sooner, because if we could pick up diabetes sooner, maybe we wouldn't see the neuropathies quite so prevalently. I don't know. I'm not a physician, but that's what I think. So, and I'm just going to wind up. So in this session, we've talked about the cost, which are enormous. We've talked about the human costs, which will help us to deal with our patients and understand their issues a little better, hopefully. And we've talked about having education and prevention and screening. And I think that's it.
Fantastic, thank you.
Thank you.
An interesting remark that you made was about the correlation or causality of depression in diabetic foot ulceration patients. It's interesting because we often see our patients walk into the clinic and they have the diabetic ulcer already, and we feel like that's why they're depressed. But it's interesting that you mentioned that depression could be the cause, and I think...
Well, I did, yeah, I said that in people with depression, it's an association, it's not a causal relationship.
But that would be an interesting study to participate in and assess for that. And then somebody had mentioned in the back there about foot screening. And if you go to the CAWC website, the 60-second foot assessment, you just need your hands and a monofilament. And it is the best 60 seconds you'll spend with your diabetic patient. So I encourage you to visit the website and look into that. Are there any questions for Dr. Gill?
Yeah.
Hi Gail, it's James Elliott.
Hi, James.
People don't know me from school on
I can't hear you.
Okay. I'm a researcher in diabetes and global health, also a person with type 1 diabetes. First question is, can I have your slides? And the second is a comment. I just was part of Miriam's group that was part of the joint advocacy effort with RNAO, Diabetic Foot Canada, a lot of other people. And I would say in Ontario at least, the ministry can't claim their ignorance, because we have been in meetings time and time again at senior level, at Minister of Health level, with Ben Matthews, with their cautions, going with the facts and figures. So I think at this point I would encourage everyone to press as much as you can politically. That means letters to the editor. That means letters to your MP. They have to answer you, they have to pretend they listen, but if you get 50, 100 of these things coming every single week, then there will be movement. So thank you.
Thanks, James. Thank you all. Thank you.